Welcome back to our three-part series on trying to understand how have health policies been recalibrated or perhaps need to be recalibrated as an outcome of the COVID-19 pandemic, and a very interesting discussion to follow, which is really, have we been looking at criteria of evaluation and solution finding in policy frameworks that are now in dire need of change? As we all know, the pressures that have been made on health systems and services, the outlook and dependency on efficacy, clinical evidence, etc., can really only carry so much weight of today's public health burden. And as we've experienced and are beginning to see as this dust settles, particular aspects of disease prevention, vaccinations, the areas of preventable chronic disease, aging and degenerative comorbidities are all issues that are soon going to be staring at policymakers and policy implementation, particularly right in the face. And that's what really this three-part episode is going to be looking at. So with that, welcome to episode 2. We've got quite an interesting title for this episode. It's called Grabbing the HPV Bull by the Horns. And to briefly explain that, the intention in our first episode was to try and contextualize the issues that we are faced with today, the role or the gap between scientific credibility and health behaviors. For those who listened in for our first episode would have heard a variety of thoughts and directions and potential priorities that were outlined. So I'd encourage folks to have a listen to that. And as we get into this particular episode, I'm so pleased to have with us Professor Tiki Pang and Prof. Wu is making a repeat, presence here for us. We're so glad to have you both. Before I go any further, it would be absolutely lovely for our listeners to really hear more about yourselves. I think that's something which will add a great deal of complexion to our discussion. Prof. Wu, may I start with you first?
Thank you very much. Thank you, Rohit. Nice meeting you, Prof. Tiki. We come from the same, we have the same university background, which is University of Malaya. I'm a gynecological oncologist, a doctor that looks after women with cervical cancer, really at the point where they present with disease. And the whole idea of prevention and talking about eliminating a disease has made me think and dwell more about how we can move the interventions from treatment to prevention. And increasingly, as a doctor who works in a hospital in a tertiary setting, I'm starting to question whether the interventions should be in the hospital or earlier on in prevention. I think HPV is just one of those diseases or infections that we can talk about as an example, because cervical cancer, as we alluded to earlier on now, is the first cancer in the history of mankind that we can talk about elimination in our lifetime. The tools for elimination is there, and now we have the difficult job of figuring out how to apply these tools, whether it's policy, acceptability, accessibility, that's critical. And I think that whatever lessons we learn about here, we may be able to translate it to other disease processes.
Thank you. Thank you for that. I should also mention Prof. Wu has an NGO that actually proves that you can actually start to make a difference by the name of Rose. And we'll talk a bit more about that as we get into this dialogue. Prof. Tiki.
Yes, just briefly. I used to be a scientist in my past life. My background is actually in microbiology and immunology. As Yinling mentioned, I joined the University of Malaya back in 1977 in the Department of Medical Microbiology, where I was teaching medical students, nurses, dental students, as well as running diagnostic microbiology test for the university hospital. I was very interested in research, particularly in dengue and in typhoid fever, among other things. And then as a result of my research in 1999, I moved to the World Health Organization in Geneva in Switzerland. I was Director of Research Policy and Cooperation at WHO in Geneva. So let me tell you upfront that I'm in no way an expert on cervical cancer or HPV vaccine in particular, but perhaps what I bring here is more sort of a global health perspective at the level of policy making, driven, of course, by evidence and research. Basically, that's what I did for the 13 years at WHO. And I retired in 2012 and persuaded to continue working half-time actually at the National University of Singapore. I was at the Lee Kuan Yew School of Public Policy, interestingly not dealing so much with medical and health graduates, but sort of future civil servants from all sectors of government in terms of I guess, increasing their awareness that health is actually in all policies. And last year, I moved back to the School of Medicine with the task of sort of broadening the blinkered view that medical students tend to have, especially in Singapore. Okay, so I hope that I will complement Yinling's in-depth knowledge about the technical aspects of HPV and cervical cancer. And hopefully we can complement each other in terms of what we say in the next 40 minutes or so. Thanks, Rohit.
Thank you. Thanks so much. And I think that's exactly this equilibrium that I've been looking forward to in this discussion. And I'm sure our listeners, a lot of whom also make up graduate students and those who are beginning their careers, to look at how the worlds of medicine and global health are coming together. So let's begin. I think as part of bringing, I guess, continuity from our first episode, terms such as lack of access, disruptions in clear, consistent awareness programs, gaps in screening, diagnosis, have begun to create this perception, real or not, that policies and infrastructures and services are really having to play catch up. So Prof, maybe I can sort of ask you this first question to sort of make this connection, and we'll get deeper into this conversation. That do you think that with the way things are looking, policy frameworks of the future, as we're now beginning to move into this new space, will be based entirely again on the clinical and scientific data alone, or is there now this look to bring equilibrium through sound behavioral health sciences?
Thank you, Rohit. I have to say I'm very humbled to be in the presence of Prof. Tiki, and I'm sure that I will learn from him. From my observation and coming to learn more about global health, I think we really need to transform healthcare. If you look at, we learn from history. If you look at the history of the first hospital that was built in Vienna in 1700s, the framework of building a building with wards for different diseases, and how medical education was then built to fit the architecture of how hospital was built. Then you start having a framework of healthcare that's also built around hospitals, specialization. And that has sort of, come this far, and we still think about healthcare in terms of hospitals and doctors and medication. Now, if we were to really put health as a priority, we need to move away from hospitals, because that's where we look after sick people, where we deal with illnesses. And so this framework of prevention needs to move away from how we think about healthcare. How do communities adopt health? And that's why when I put it when I think about cervical screening, I see the same thing. Screening is done in hospitals with cold instruments by specialists. It doesn't need to be so. It needs to be adopted in a community as part of a lifestyle that, I will uphold my health. It's not a scary experience. So whether it's policy or behavior or behavioral change, I feel very strongly that whatever interventions we take, we have to disrupt the idea of healthcare being in hospitals.
That's a great place to start, because yesterday, Prof. Tiki talked about the 6 pillars of global health. And I think it touches upon, Prof, what you just said, that if the legacy has been that I must go to this structure for my cure, for my well-being, then how will we ever try and bring this almost spontaneous prevention aspect, just as it is within our homes, within our communities, yet my health has to be in this one little separate place of illness and sickness. Prof. Tiki, how would you react to that in the context of those pillars, which I think were great sort of frameworks or parameters to perhaps build off that?
Yeah, thanks, Rohit. What I mentioned were 6 pillars, or I think the better term is building blocks, not so much of global health, but of health system in countries. That is, the health workforce, the supply of medicines, the delivery of services, information systems, and importantly, leadership and governance. But I think in the context of what Yingling just said, I couldn't agree more with her. And what I would like to mention here, perhaps on a sort of a global level, I think most of our listeners have heard of the Millennium Development Goals, the MDGs, that ended in 2015. And that in 2016 was replaced with something called the SDGs, the Sustainable Development Goals. Okay. And SDG 3 in particular is focused on improving health and well-being. So it goes beyond just the absence of disease. And it goes to the heart of what Yingling was saying. And if you look carefully at SDG 3, regardless of the focus of, say, communicable disease, non-communicable disease, violence and injuries, maternal health, etc., the underlying foundation of that is universal healthcare. And the focus of universal healthcare is prevention. The focus is not hospital with fancy equipment, but primary care facilities. Okay, shifting it, as Yingling said, to the level of communities. Okay, so there is a global compact. Every country, I believe, has that responsibility to provide universal healthcare. And Indonesia has been struggling with it because it's expensive, obviously, and they found out that if people think universal healthcare is giving coverage for heart transplants and expensive cancer medication, they're wrong. The only way forward is to focus on primary care, on immunization, on bed nets for malaria, on nutritional supplement, on promoting breastfeeding, that sort of stuff. And if you want a good example of a country that's gone that path, that's Thailand, where in the last 10, 15 years, they've shifted the way they've spent their budget. Instead of 70% in urban areas, in tertiary fancy hospitals, it's now 70% in the rural areas, in primary care clinics. And they have managed to keep what they call the 30 baht policy. Every Thai citizen pays 30 baht to access all kinds of health services. So yeah, I think just to support what Yingling said, that there is a global compact that is absolutely focused on prevention and primary care, rather than treating the disease, which once you have to see Yingling in her clinic, it's too late in many cases, and it's going to be very expensive for the healthcare system.
Correct.
It's almost becoming customers of wellness rather than customers of illness. Now, that sounds like exactly where we need to be headed. There's the question of HPV, and I think this is why we selected HPV as one of the areas that you would expect universal health coverage should be or would be identifying as a priority. I mean, if you look at some of the numbers, particularly in our region, it's in the high percentages for affecting those, particularly with less access maybe to awareness programs and so on. And the fact that I think, as Prof. Wu mentioned, it's preventative, which is absolutely insane as to why wouldn't this be something which is after over a decade or two that testing should be made more mandatory, is yet still not being adapted or adopted to. So if I may, from the context of what you just said, Prof. Tiki, that the UHC values that are now coming through now and possibly, hopefully, will increase, what would there be, or what's holding it back, rather, that we're yet not seeing that level of uptake in HPV? We're not seeing that either community prioritization. Is it financial? Is it cultural? Are there nuances that we need to be looking beyond perhaps the sort of systemic, more in terms of behavioral? Prof, would you like to have a go at that?
Yeah, I think maybe for the benefit of our listeners, I'll just put the big picture of how cervical cancer can be eliminated, just for the benefit of the listeners. So to do that, WHO, the World Health Organization, has set a target to be achieved by 2030, which is 8 years from now. In that, 90% of our adolescent girls should be vaccinated with an HPV vaccine. So 90% of 13-year-old or 15-year-olds. Historically, we started off with 3 doses of vaccine, and we talked about the infrastructure to get a girl back 3 times within the course of a year. Then the science showed that 2 doses were sufficient. And now, this year, we're starting to see evidence that 1 dose may be enough. And in fact, the UK has just come out with their guidelines. JCVI have just said that, look, with a disruption of COVID, please get at least 1 dose in the arms of the 15-year-olds. So first strategy, vaccinate 90% of your girls. Second strategy is to ensure that 70% of women are screened with an HPV test at least twice in their lifetimes. So not like the traditional pap smear, where you need to have it done every 3 years. This is a HPV test, PCR test, similar to COVID, but twice in your lifetime. Third, which I think is most important, is that those who are screened positive and who are found to require treatment, 90% of them would receive the appropriate care. So against that background, we then ask, if this is so effective, why are there some countries still not vaccinating the girls? There's been so many cost effectiveness studies done in every single type of economic setting to say that it is cost effective. I think affordability may be one issue for many countries. Many countries just don't have the finances or the budget, or maybe it's not been argued, or the value has not been demonstrated. So all these things, I think Prof. Tiki will be able to share. How do we change policy at a country level to make sure vaccines get into the arms of girls? Then we have to deal with the societal or behavior of parents allowing girls to be vaccinated. So I think I leave that vaccination portion for now, and maybe Prof. Tiki can share how he thinks different aspects can change policy for HPV vaccines.
Absolutely. And Prof. Tiki, before you do that, let me contextualize with live examples. So some years back, when I was sort of doing some research around vaccinations for cervical cancer, and having interviews with pediatricians, GPs, the question to me was as simple as, how do I bring up the discussion of sexual activity, genital warts, all that other stuff with parents of a 11-year-old? Why lay that responsibility on me? I have a practice to run. So the reality in terms of where does this initiation of dialogue begin? Are we providing for enough, in some regards, security aspects for this conversation to happen in a way that is appreciated? And at the same time, as a parent, to be considering that I went there for a regular checkup for my little girl, and suddenly here I am being told about certain things. How does that counter? So I bring that in the context, Prof. Tiki, that as we talk about what some of these preventative policies may be, and HPV sits in that very kind of cusp of, is this really something that's relevant? Is this something that's really going to be culturally acceptable? And then who pins this? Who puts the bell on this cat to say, how do we get this going? Sorry, I just want to contextualize this, Prof, before we try and articulate what possible policy solutions might be there.
No, I think that's very helpful to put it in that context. But let me begin by sort of, repeating something that's been repeated many times. What happened in the Philippines 2 years ago when 400 children died of measles because there was a reduction in childhood immunization. And people say, it's a tragedy that 400 children can die from a disease which is totally vaccine preventable. And it's exactly the same analogy with cervical cancer. This is a deadly disease that is now totally preventable with a vaccine. And to allow that to continue to happen, it's just morally unjustifiable. So I think, people need to understand the scale of that problem. Okay, sorry, I digressed a little bit. In terms of why is it so difficult to change sort of policies in countries, and I did a little bit of reading before the podcast. I was actually struck by the level of coverage of HPV vaccine globally. Yingling, correct me if I'm wrong, but it seems globally on average is something like less than 20% total global coverage. Pretty high in Europe and in North America, but in Africa and in Asia, dismally low. And in some countries, absolutely, like 10% even. So
Correct.
what are some of the factors here that makes it so difficult for government to include this in their policies? So I think the first one, I think Yinling already mentioned, that's affordability. And remember, in many low and lower middle income countries, governments are having to deal with limited resources and competing priorities, okay? And it has been made a lot worse because of COVID. So that's one factor. The second factor, as I know from my WHO days, the expanded program for immunization, the EPI program, it's already very, very crowded. So there is also sort of a logistic challenge there of introducing yet another vaccine, okay? And because this vaccine is administered parenterally, it does require some level of technical expertise. It's not like the old polio vaccine where you just drop things into the mouth. So that's sort of a health workforce limitation. I think the third issue, I think, is what Yinling has already mentioned, and that is parents' acceptance of the vaccine. Because at the end of the day, the group that you're targeting, adolescent girls, is where you need definitely parents to support that, okay? And I don't know whether I'm a bit out of date here, but I believe there were some safety concerns about HPV vaccine some time ago, okay? And in the context of hesitancy around COVID vaccines, okay, that's likely to come up to the surface again. HPV causes infertility. That was one of the fake news that I heard many years before. So obviously, safety, parents' acceptance is another issue. And just if you remember what happened when antiretroviral therapy became available, I think there is a real concern among some parents that giving the girls HPV vaccine will promote promiscuity amongst them when they become sexually active. So there are multiple reasons for that. But from a government perspective, I think that issue of competing priorities and affordability is one. Let me just finish by saying, I think Yingling sort of highlighted the fact that in terms of the research evidence, okay, it is beyond doubt the benefit and the value of this vaccine. So, as a scientist, And Yinling, as a clinician researcher, you go to a policymaker, and all my years at WHO, I used to go to say the Minister of Health or the DG and say, hey, look at the evidence. What are you waiting for? The reality is evidence and research is not the only thing that they have to consider when they're making these decisions. But let's not get into that, because I teach a whole module on how policymakers sometimes, it's not that they don't want to see the evidence. Let's face it, no policymaker wants to make bad policy, but evidence is only one factor in the policymaker pie. I better stop there, otherwise I just get carried away.
It's one of those topics where we do need to get into the weeds. But Prabhu, let me swing back to you just real quick on this very, I think, important perspective Prof. Tiki brought up, and that's this misconception on promoting promiscuity or the safety angles. It's so true that these are issues that even after a decade yet still persist. It'll be great just to hear your perspective and perhaps some sound advice for our listeners to try and maybe contextualize that, and any answers you may have.
Sure. I think with any introduction of an intervention, a health intervention, just as what you see with HPV, you observe it all over again with COVID vaccines, the causal relationship and associations. So, when HPV vaccination was first given, when you give it in such a large scale, I mean, already before any intervention is given, you will have the odd neurological disease, allergic reactions. But then when you start giving everyone the vaccine, HPV vaccine, then the association is turned into a causal relationship. And that's the same with what we see in COVID. I had my COVID jab and my cancer has recurred. I've had my COVID jab and I've had a stroke or a heart attack. And how do we remove these this sort of misunderstanding or myths? Yes, the science is there. We must be open to look at the science, because sometimes after large randomized control trials are done, you see an effect later on when it's adopted into a policy and population level. So as a scientist, you must still be open to rare side effects. But if the evidence shows that it works, we must also counter the myths. One thing about doctors and scientists, we don't communicate very well. We don't sell facts very well. We are using all this jargon, this scientific language, Whereas the people who sell myth or complementary medicine, they really know the right language to use when it comes to talking to the public. So you see the WhatsApp messages that are spread, right? About, I had a HPV vaccine and I can't walk the next day. And that caused the whole downfall of Japan's vaccination program that time. And years down the line, we show that there's no relationship, and yet it was still so slow to be taken up. So these are stories. And similarly, COVID is facing the same situation now. Shown to work, but the myths are really at large.
Yeah, it's true. I mean, I wrote a paper last year, which in my research showed that one of the biggest sources of media disinformation, I found it unfair to tag it as the sort of the relatives WhatsApp chat. In particular, it was more the aunties than the uncles. I have to say, uncles are equally many times contributing to it. But consider that WhatsApp viral messages have become a key source, and how do you counter that? So I think absolutely right. I mean, I think these are also factors that come in, and also I think I think what Prof. Tiki said earlier about this fact that, if I'm vaccinated, will I be more promiscuous? I mean, it just, when you think it through and you start to sort of peel that back, you're like, no, why would I suddenly say I'm going to start engaging in promiscuous behavior because I'm vaccinated? So there are these factors that come into play, and I think you both sort of positioned this exact point that we've got to find good policy, brave policy that understands these perspectives and these nuances. Let's maybe shift gears to a topic that I think is probably allied to all of this. Now, we've talked about the fact that there are a certain number, 70%, that need to be screened using this HPV test. It's minimally invasive. We would then be close to touching our 2030 goals. Yet, at the same time, we find that these are hard to reach numbers. Is there an aspect, and I think Prof. Tiki touched upon it, on logistics and resourcing? Aside from the sort of clinical data, the efficacy, the safety, the behavioral nuances, is there something in the middle, which is almost this, how resilient or how robust is our logistics, is our resourcing, is our infrastructure that could possibly cope with, let's assume, an average of 70% screening happening? Is that something which comes in the way of things? And I'll open that up to anyone who has a thought there.
So in terms of resources, if you compare the old way of doing cervical screening, you need a woman to have a pelvic examination, you need instruments, you need cytopathologists to read their pap smears under microscope, highly human resource intense. Infrastructure must be able to cope with that. Now, when we talk about HPV testing, you're talking about a molecular test, a PCR test. And now it's easier to talk about this because everyone is familiar with a COVID test. So we did this. I know this is a podcast, but you're talking about a swab, a simple swab that takes a low vaginal swab, and you run this on the same machines that run COVID PCR. You do a HPV PCR, and the answer comes out as a yes and no. This is such a huge paradigm shift. And you know what I think, what the barriers are? I think the healthcare professionals are not ready yet to promote this widely. If I speak to many of my colleagues, including the medical school teaching still, we're still teaching pap smears. We're not ready to let go of a practice that has been there since the beginning of the practice of medicine. And you have to be radical to be able to accept that there's a new method now. It can be done large scale. And women can do it themselves. You don't even need a doctor to do their HPV test, self-testing for HPV. So big radical ideas, disruptive, transformative, and doctors are very slow to accept change. So I think it will require a bit of time, but we will get there because science has shown that this is such a superior screening method.
And in a way, we're saying that the screening, therefore, doesn't have to take up the time, effort, and energy of specialists, but could be done at primary care nurse levels, at selves and themselves doing it. Do you think, Prof. Tiki, in that context, as Prof. Wu just outlined, I mean, in a bizarro world sort of way, that there might be resistance from the medical fraternity or policymakers to say, does that take away from the role and responsibility of the medical community? Almost like, is there a chance that this might be seen as taking away rather than alleviation?
I don't really think that is such a sort of an insurmountable barrier. I think more and more, especially in developing countries, the health systems are getting more and more used to what is known as task shifting. So those invasive, highly technical procedures that Yinling mentioned before about pap smears, how it has to be done by an obstetrician gynecologist and then qualified pathologist to look at the microscope. I think a lot of that as the technology has improved, we are more and more moving towards what is known as point of care kind of diagnostic test. In this case, I guess, point of care at the level of primary care clinics. And I think people are more and more used to, for example, not necessarily having to have doctors do the necessary collection of the specimen. In this particular case, I'm pretty sure midwives would be perfectly qualified to do that. Even in many developing countries, what are known as traditional birth attendants, they're not qualified midwives in that sense of the word. But I was very impressed with the advance in the technology that Yinling showed us just now. Although I don't know, I'm 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 not a obstetrician or gynecologist, but I would maybe say that collecting a low vaginal swab is probably not as straightforward as collecting a nasal swab for COVID. Okay, so there could be still some level of training involved there to make sure that you're collecting the specimen in the right way. But having said that, assuming that you are able to collect the specimen, and better still, if the woman can do it herself, the technology around the PCR itself is just incredible how it has sort of progressed so much in terms of the cost of the machines to do the PCR, in terms of the portability. There are now, battery-driven PCRs that have been tested in the field. The military, for example, have been doing this for anthrax for many, many years in the US. So I think the parallels in the technology, but getting it adopted at a certain level, and that is a different challenge. It's not about the scientific challenge here. It's about, once again, about competing priorities. And I'm not sure how much that test actually costs compared to, say, the COVID test. And once again, in terms of the volume, when you increase the volume, I'm sure the cost of those tests will drop dramatically. But given the level of testing coverage at the moment, probably that hasn't happened yet, but I may be wrong.
Correct. No, Prof. Dicky, you're absolutely right. The World Health Organization is actually championing this, just like what they've done with TB PCR previously. TB used to be so expensive, TB testing, and when the numbers went up, the prices came down, and that's exactly the same thing stakeholders are trying to do with HPV testing. We learn from the era of HIV testing and HPV testing. So that's exactly where we are now.
But let me just add, I think the other thing that, the HPV advocacy suffers a little bit from, it's probably the classical dilemma. When you're talking about COVID, you're talking about very acute infection. Somebody gets sick, somebody can die within a week. Here you're talking about preventing a cancer that is, many, many, many years down the road. So that sense of urgency may not be there. I mean, that's, the typical dilemma between acute infectious diseases and chronic disease.
Correct. And that's why we have such a huge issue with diabetes and heart disease and cancer, because that's what when we first started this conversation, how do we move healthcare to prevention? And that's what I shared with Rohit. I think it's a behavioral fight. It's how do we change how people think? We are very last minute, I guess. We just wait until there's a symptom. How do we change our communities to adopt preventive strategies in a manner that's not inconvenient to them, that's within their control, at an early stage rather than later on?
Yeah, but Yingling, I mean, I think that's fine, but I think there's a bigger underlying problem that has been shown up very clearly during the COVID pandemic, and that is the low level of health literacy. Okay, I'm not talking about science literacy. I'm talking health literacy in terms of healthy behaviors amongst the population, even amongst educated people. Okay, so that's a much more, let's say, structural problem. And I don't even mean that we should be improving health literacy at the level of universities. I'm talking about secondary school, even primary school. Because unless the overall literacy about health is improved in the population, it's going to be an uphill battle.
Or where you go to get health care. If I'm sick, do I go to a private GP? Do I go to a hospital? If I have an abnormal screening test, which hospital do I go to? How do I get to see a specialist? It's that type of basic question that perhaps we should be teaching in school.
Yeah, exactly.
Very
Yeah.
true. One aspect that I think you've both been touching upon extremely importantly is the realization that health literacy is paramount before anything will change.
Sure.
What's been coming up in more and more conversations is that, well, has technology finally caught up, that it's more about digital literacy that will enable you to have health literacy. I know that sounds a little convoluted, but to pick up on Prof. Wu's example there, that if I have an abnormal result and I want to find out where do I go, who do I go to, where it's not like it used to be where you just pick up a phone and speak to an operator, right? I mean, now you have to know how to manage apps, the digitization of health systems. Here in Singapore, I know that there's been a great deal of concern that will, particularly an aging cohort, be able to manage their disease with all of the e-triage and EHCRs, etc., that will be necessary for you even to make appointments and so on. So there is now, I think, as you both rightly pointed out, a real convergence of digital and health literacy becoming paramount. One can't happen without the other. Fascinating. I mean, I think as we're sort of breaking this down, what's becoming clearer, and for the listeners, maybe to remind it again why this is so significant, cervical cancer affects around 500,000 women, causes 250,000 deaths worldwide, and 80% of deaths are occurring in less developed countries. So I think that sort of accentuates why the professors here are particularly passionate and talking about these nuances. What's coming across is that we've got perspectives that are required and necessary from, the digitization, the health literacy, the value that behavioral science can certainly play. There's one aspect that I think in the time we have to touch upon, and we mentioned this in our first episode, is political will and brave policy linked with regulatory presence. Maybe I'll just sort of throw this to Prof. Tikki and Prof. Wu, that where do we sit right now in our region or in our places that the right regulatory presence, and by that insurance payers, their recognition of their role, the political will that this has to come together, are these two almost like handshaking to come together, and can much be achieved with the right balance there?
Yeah, obviously, I think it's the right balance. Regulations, political will, which all links to accessibility. Okay, how do you make the vaccine and the testing, for example, much more accessible, much more affordable to those who need it the most? And as we have already said, it's not about just convincing policymakers about the fact that the evidence is beyond doubt that it has great benefits, but there is the need, not just political will and commitment, but to put your money where your mouth is, amongst all these other competing priorities, political exigencies, pressure groups, the issue of lobbying groups, in some cases, the power of religious leaders. Okay, so I don't envy the policymaker in a sense, and let me just end by a quote that I use a lot in my classes. Okay, and this comes from Sir Michael Marmot, who was the chair of the WHO Commission on the Social Determinants of Health, and this is what he said about policymakers, the dilemma that faces them. Science does not engage with blank minds that get made up as a result. Science engages with busy minds that have definite views on how things are and how things should be. I sympathize with policymakers, and if the next election is 6 months away, he's not going to make a decision that's going to jeopardize that. So anyway, I'll stop there. So that's the dilemma of the policymaker,
Absolutely. Prof. Wu, what would be your thoughts to that?
Likewise, I don't envy policymakers. Being a scientist is much easier. Being a doctor is much easier. but this is it, right? We need to engage with them. We need to educate them and update them. So let's use an example here in cervical cancer screening. I think I spoke about this. So where policy and science meet. So we spoke to some insurers, the major insurers in Malaysia, and their policy is still to classify HPV as a sexually transmitted disease, which means that you cannot compensate someone or reimburse someone financially if they go for a screening test, which is a proactive behavior, and something abnormal is found and they're treated for it at an early level. So by right, your policy should be rewarding them, not giving them punitive measures whereby you say, oh, you've got a sexually transmitted disease and therefore I will not pay for your reimbursement.
Wow.
Now, so this is where the doctor and the scientist needs to tell the policymakers, look, HPV infection is very common. It's not a disease. It's when our immune system is low that someone will have persistent infection and then there may be changes in the cervix. And therefore, a person who screens and gets treated early, they will save you so much more money if they are found to have cervical cancer. And that's where these conversations need to happen. Just as an example.
And that's a wonderful example. And for policymakers, that cost-benefit argument is sometimes the most powerful. If you tell a policymaker that by giving the vaccine, by giving the test, you avoid, I don't know, 8,000 cases of cervical cancer 10 years down the line, you will save $60 million. That's the kind of argument that usually works best.
And we have learned this from HIV as well, because now patients with HIV live a normal age. And they used to be removed from policies if they have such a test. No, you shouldn't. You should have the diagnosis early. I take the treatment for it and I live a long, normal, healthy life. You don't penalize them from having the test. These are examples that we need to engage with policymakers.
Right. You should actually provide incentives for them.
Correct. Incentivize preventive measures that are taken by individuals.
Right. Absolutely.
Imagine that. Imagine a time when we have policy that could actually incentivize for the courage and the ability to say, I need to look after my health. I'm going to do something about it. Oops, things didn't go so well in my test result, but I'm going to have the support and the nurturing to see me through this from an infrastructural point of view and from a supports point of view. Wouldn't that be a brilliant place to work? I think I was giving the example last time to Prof. Wu that there was a time when my mom came to me and she had something on her lips. And I said, what's that? And she said, it's herpes. And I said, herpes, only to realize that herpes is nothing. It's just a thing that happens to everybody. So the normalization of terms, HIV, the normalization, the necessary normalization of certain things, the HPV normalization, bringing that into, I guess, more of an acceptable mainstream. I think this is where we've been sort of coming to. This has been an absolutely riveting time. And this is exactly why we needed to break these discussions into 3 episodes. And I'm sure even that would never be enough. But at the same time, at least we have now begun to make some momentum, I must say. And I think if I may want to ask both of you, if there's any last kind of statements or words as we sort of proceed into our next episode soon, what would you want to leave our listeners behind with? Perhaps Prof. Wu, I can start with you and then on to Prof. Tiki.
I think I've always believed we have to start the conversations. Scientists, doctors have to start having conversations with economists, with actuarists, with politicians. We don't generally meet, Doctors always meet with doctors. Financial people meet with financial people. And that's where I think to really make changes that are disruptive and transformative, we do need to have these conversations going.
Prof. Tiki?
Let me just finish on what I think is probably the biggest threat to the post-pandemic era after what we have seen. And that is without a doubt the dangers of misinformation and fake news, transmitted through social media. And it's a case where, as you mentioned yourself and Yinling mentioned, that the people who promote these falsehoods are much more effective in using these technologies than those of us who try to defend the truth. Okay, so that's the big challenge, I believe, technologically. And let me end by quoting Yuval Harari, the author of Homo sapiens. He said, "We humans know more truths than any other species on Earth, yet we believe the most falsehoods." So that's our challenge.
Absolutely. That's a great way to punctuate this session. I want to thank Prof. Dickey, Prof. Wu so much for their time and taking this time out of their busy schedules to continue this dialogue. Our next episode is actually going to be the culmination of this time together. We've called it Meeting at the Middle, Finding New Ground.
Okay.
And then hopefully we'll find some resolution to a lot of the information and necessary discussion we've had right now. I want to thank our listeners for following us, for listening to us, and for the feedback that you've been giving in as well. For more information, you can always go to www.thevoicesprojectasia.org. And again, as always, what we're doing here is just trying to make a difference. It just takes one step at a time. Thank you so much, everyone, for listening. And thank you, Prof. Wu. Thank you, Prof. Dickey, again.
Thank you.
Thank you, Rohit.
Thank you very much.